So, thanks for coming. My name is Curtis Olson. I am a staff nurse in the emergency department at St. Elizabeth Regional Medical Center in Lincoln. I'm here speaking at the end of March. Who's here because they suddenly realized they needed 2 more continuing ed hours to get their national registry up by tomorrow. Excellent. Okay, that's why we scheduled it tonight. Thanks for coming. So I'm going to talk about head injuries tonight. It's called Head Injuries Inside and Out. I'll talk very briefly about my background, and then we'll go to the presentation here. I work at St. Elizabeth Regional Medical Center in Lincoln. It's a 250-bed community hospital, known for our burn center, where I worked right out of nursing school for my first year. Also have our ER has about 25 rooms, see about 30,000 patients each year. Going through the alphabet soup behind my name, I have a bachelor's in nursing from Bryan LGH College of Health Sciences. A long time ago, I got a bachelor's in literature from George Washington University in Washington, D.C., where I'm from. Then the RN is from Bryan School of Nursing, back when that's what it was called, when they had a diploma program. I completed that in 2003. Got a paramedic certification through Creighton University, and then got onto the Lincoln Fire Department. Really couldn't do the 24-hour shifts. I prefer to work overnight, but I like 12-hour shifts, working like a dog, and then going home and going to bed. My original EMS training was at Bethesda Chevy Chase Rescue Squad in the suburbs of Washington, D.C. in Maryland. Very good place to get my initial training because we had a lot of good training there and saw a lot of interesting stuff, including here's me on a scene of a big MVC on one of the highways up there. As an EMS provider, I've been in the newspaper 3 times, 10 years as a nurse, never been in the paper. So tonight we're going to talk about head injuries. Our objectives are going to understand the anatomy of the head. I'm kind of an anatomy nerd, so we're going to go through that probably in more detail than you really need to for EMS, but from that springs a lot of knowledge that you'll get. Understand the pathophysiology of a lot of different sorts of brain injuries. Understand those external signs of those internal injuries, and finally understand your management as EMS providers for those injuries. It's called Inside and Out because we go through the anatomy and pathophysiology of what's going on inside, and then how that plays out outside in signs and symptoms so that you can recognize those and treat them from there. So we're going to go through a lot of case studies too, and here are some of the people we'll be talking about. Tom, Missy, last names taken away to protect health information and identities and such. But Natasha and Phineas and some people I've known. I put this together first time in 2009. Some of these case studies. One in particular we'll go through is a little bit stale, but even in 2009 it was a puzzle. You'll understand it when we get there. In any case, the first one we're going to start out with is Phineas here, and maybe you've heard of this guy in your EMS or nursing training. Phineas Gage. Phineas was a railroad worker, which involved moving a lot of rock around. And when you want to move a lot of rock around, you get a large number of people, but also in those days also you would get a large amount of explosives. And that was Phineas's specialty. Phineas had what was called a tamping iron. So they would drill into the rock, they would put the dynamite down, and then they would tamp it down to make sure it was down at the bottom. So Phineas was born in 1823. He had an injury in 1848, but did live on quite a bit beyond that, which is kind of surprising considering the slides of the injury that I'll show you here. So in 1948, working on the railroad, hitting his tamping iron, and in the process of that, there was an explosion, and that tamping iron went up and went through his skull, a little bit like this. Underneath his maxillary right, missing the eye and to a certain extent missing the eye and the orbit. You'll notice back here, actually, he did lose this eye, but it almost looks from this like it went behind the orbit, that part of the skull, and then out through the top. Now, in reading about him, you may have also read about him if you ever took a psychology course. And he's kind of a case study in losing part of the forebrain, losing the parts of the brain that control personality, higher functions, and things like that, but leaving intact the structures that control respiration, sensory motor input and output, and things like that. So he did have some personality changes after this. Most people kind of say that he became more impulsive and things like that, although other researchers have come on since then who say anyone who had a theory about brain anatomy and personality back then kind of looked at his case and took little bits and pieces, the facts that they could puzzle out, and use them to prove their theories. And some of the theories he proved that were proved by his case were kind of wildly divergent. A kind of later imagery study, kind of a wax reconstruction of his face. These are kind of early or mid 20th century reconstructions, and then a much more recent MRI of the skull. His skull is in the Medical Museum at Harvard University, and so they can study it and do these more modern sort of MRI images of what happened. So here in this image, you can see it, that it did go through the orbit and through the eye, and looks a little more anterior in terms of the portions of the brain it hit than some of those other images there. I believe the tamping iron, which he used, would carry around, it had a special engraving. Yes, this is the iron that Phineas was carrying that fateful day. I had some inscription like that. That also is at Harvard. But he did survive this. So this is kind of an old school one, but we have something a little more modern, pretty much the same thing, although with the entry and exit wound reverse. This is a gentleman just last year, I believe it was late last year, October, November, in Rio de Janeiro. Eduardo Liete, 24-year-old construction worker. He had a hard hat on, just doing something on the ground floor of a building. An iron bar fell from the 5th story, entered through his skull, came out. He went to surgery there. They did remove it. He did survive. A quote from the neurosurgeon who worked with him, Dr. Montero, said he did survive. It was okay because the bar entered a non-eloquent area of the brain. Now, I'd like to think that most areas of the brain are at least somewhat eloquent. I'm sure there's some sort of translation from Portuguese that renders that a little bit odd, but maybe he meant something more along non-essential or something like that. But catastrophic injury that is pretty survivable. And my brother-in-law's brother, which I don't know what that makes him, had nothing quite this crazy, but he was in a motor vehicle accident that involved something coming through the windshield and taking off, entering his skull, and he ended up losing a fairly good portion of his forebrain. And like what was reported with Phineas Gage, he's a lot more impulsive. He got a court settlement and really likes to spend that money and go out and enjoy life to the fullest. So very much a personality change in him, but living a very fulfilled life. He was an electrician, not really doing a lot of electrical work nowadays, more just kind of spending that settlement money. So, but out there, and he's actually more eloquent than he was before. So let's talk about what the parts of the brain and things when they get pierced or removed, or things go through them, what we're dealing with and what kind of external signs we can expect here. So our frontal lobe, this was Phineas and this other gentleman, and my brother-in-law's brother. This is the area that controls emotion and personality, complex functions, some of your fine motor skills, not all of them. Recognition and motor functions. Some gross, usually more of the finer stuff there. Parietal lobe is sensory input. So injuries to the back of the brain, you're going to have patients who are going to lose a certain amount, some senses, maybe become deafened. Well, if you have a head injury, especially like in a combat situation with a blast, there's certainly going to be a certain amount of hearing loss. But they're going to have some sensory loss if you have really catastrophic injury to this part of the brain there. Temporal lobe, right by the ears, controls hearing. Also, taste and smell get routed through there from the tongue and into the forebrain where they're really sensed and sorted out there. And short-term memory. So you can have somebody, I know another gentleman who actually had more of a diffuse injury. It involved a carbon monoxide suicide attempt, which he did survive. And yet another brother-in-law. My wife is the 10th of 10 kids, so I got a lot of in-laws, and they all have friends who've had brain injuries. In any case, this gentleman had a hypoxic brain injury, and he was living in Madonna at the time. And when my brother-in-law visited him, he said, I want to have lunch with you next week, so just come back on Thursday. He looked at his he had a calendar, he could function that much, and he put John down for Thursday and said, come back on Thursday and just tell me that you're going to take me out to lunch because I won't remember it. And he at least had the amount of, had adapted, as a lot of brain injured patients need to, had created adaptations. So he would tell people, I'm not going to remember this, but this is what I want to do. So that's how he would set up his calendar. Occipital lobe, that is, again, receives sensory input. The sensory input starts out there, and then it's mediated through the temporal lobes and some others, and eventually makes its way to the forebrain where memories are created. Long-term memories are created after being short-term memory there. And then the cerebellum down here, fine motor function, a little more important in terms of moving around, things like balance, coordination, what we call proprioception. So if I were to close my eyes and put my hand here, I know that my hand is up here, but if you have some sort of brain injury that affects that, you lose that senses, and you close your eyes and you really don't know where your hands and legs are in space. So that controls that kind of stuff. And then the brainstem, well, this is more than a little bit important, obviously. This controls respiration, cardiac function, hunger and thirst. This is the top of the spinal cord entering into the brain. And any sort of injury to this, which is very likely in a lot of these things that involve swelling in the brain, and we'll talk about that, will involve some pretty catastrophic injuries to this and a pretty quick death. So we'll talk about, that's anatomy and function. Let's talk about the skull and what's inside it and how this all plays out. So first of all, the brain uses 20% of your cardiac output, a lot of blood going to the brain through those carotid arteries in the neck. 20% of your oxygen circulating is used there. And then 65% of your glucose is eaten up by your brain. So there is a lot going on there. And it is all inside the skull. Excuse me, I'm going to just kind of, no, actually I'm going to keep that there, sorry. It's all set up in the skull, which is a very elegant structure or collection of structures. Now, has anyone taken a college-level anatomy class for nursing or pre-med or something like that? I remember first week was pretty boring. We did connective tissue and dermal tissue, and it was like, wow, this is going to be just horrible. Second week, they hand us a skull, hand us a list of like 120 landmarks, and say, here you go, know these by Tuesday. I was like, ooh, I am not in Kansas anymore. Well, I never was in Kansas. I was in Nebraska. But that's a lot funnier when I say it on the East Coast. In any case, there is a lot going on. You think of the skull as this kind of monolithic structure, but is really made up of a whole lot of bunch of different bones, including the smallest bones in the body, the bones in the inner ear, which allow you to hear, and those are the three smallest bones in the body. So here's kind of an exploded view, as the terminology is, of the brain with the parietal, frontal, maxillary, mandible as a jawbone, and all these lobes that come together in these joints called sutures and form this very good protection for the brain, which needs protection. But that box is pretty much sealed. So if we have some sort of insult to the brain and alterations of what is inside that sealed box, we can have some big problems. This is called the box theory, or the Monroe-Kelly hypothesis, which is after the names of the neurosurgeons who first thought about this. So inside that sealed box, inside that skull, you have the brain, obviously. You have blood, and you also have cerebrospinal fluid. And alterations in the volumes in any of these, or especially if you have any of these increased volume, you're going to be putting pressure on the other two and having big problems. So here's the inside. Not to mention the inside of the skull, especially on the bottom, may be difficult to appreciate on the slide there, but there are a whole bunch of little ridges and valleys and things like that. So if you have a pretty significant impact to the skull, the brain is going to be bouncing around inside of this, and the brain is going to be, parts of the brain are going to collide with all these structures inside. And then I've talked about the brain. You know about blood, I'd like to think, if you're in this business. Cerebrospinal fluid, you might not be quite so familiar with. This is a fluid that circulates around the brain and eventually makes its way down along the spinal cord. So if you know anyone who's ever gotten a spinal tap or lumbar puncture is our more refined name for it, where they're pulling off some of the CSF off the lower part of the spinal cord. This is fluid that is circulated through these ventricles in the brain and eventually flowed down here. And this provides clears waste out of the brain, but mostly it provides protection. So if we do have swelling of the brain, it can swell into these ventricles and provide a certain amount of leeway for swelling in the brain. Old school, before we had head CTs, if they wanted to see if there was a bleed in the brain, they would do one of these lumbar punctures and see if there was blood in the CSF that had circulated down through the spinal cord there. So those are our players inside the skull. And then also protecting the brain, in addition to that CSF, which kind of cushions the brain on the outside, we have these protective layers, the meninges. The dura, the arachnoid, and the pia. I won't go into too much detail on these except to say that, well, first of all, if you need to memorize these for an anatomy class, you can remember it is you have the brain and then the pia, the arachnoid, and the dura mater, and that's PAD, the brain pad, and that's what protects you from the brain on out. The dura mater, it's Latin for tough, and from neurosurgeons, I've heard this described as being a lot like a thin piece of suede. Very tough and fibrous, and has a certain amount of blood vessels running through it. Same with the arachnoid, and the pia is this final one that kind of protects the brain. If the skull is breached, you still have some other things protecting it. So when you do have a blunt impact to the skull and to the head, as I said, that brain can be bouncing around inside the skull. And not only do you have, picture a person inside a car that hits a wall, and the car stops, and that person keeps on going, and they will hit the front of the car, the steering wheel, whatever. And they'll probably bounce around inside of the car, depending on the hit force of that impact. Same thing with a head injury. You're going to have what they call the coup, which is French for hit or impact or something like that. And the brain impacts the front of the skull, and then a counter coup, a second impact, where it'll bounce around some more. So you might have some significant brain trauma up front here, but also back here as that brain has banged around. And maybe a little bit of trauma also on the base of the skull as it's hit. The cerebellum and pons and such are impacting all those other ridges that I pointed out before. So when you have these sorts of injuries, you're going to have bleeding in the brain. And we're going to figure this out with a CT scan in the hospital. And here's an essentially normal CT scan. The CT scanner, has anyone ever looked at aside from this, looked at CT scan images? It's basically an X-ray deli slicer. So we send them through, and the images that come through are these cross-sectional images and just stacks of them. So we do this to heads, to necks, to chests, to bellies, all this kind of stuff. And there are, if you go to a medical bookstore, atlases of cross-sectional anatomy where they'll show they've basically taken a body, frozen it, and run it through a CT scanner, and then they've taken that frozen body and run it through a physical slicer and taken pictures of each of those sections. So they have a picture of the CT scan, and on the opposite page, the actual cadaver scan. They do it to cadavers, not to people. And then you can have a really good map of the anatomy and its corresponding imagery there. I'm going to, for my video, I'll have you look, focus on the screen here, because I'm going to show a pretty remarkable website, and we'll go through a little bit of anatomy here. Through this, and you can get a sense of what these scans look like. This is, well, I'll show you first the website, Head, Neck, Brain, Spine. Pretty remarkable site, and they have this, and this is, I'm sure this is available as an app or something too. So to look at this on your smartphone would be pretty cool too. So I'll direct your attention over to your left there, and our axial images. And this is our typical imagery as we look as we scan a person with a head injury after an accident. We go down, and you can see the sutures of the skull up there. I'm going to see if I can use my laser pointer. So you can see a couple of joints of the skull there, and then we move down, and we get into the actual. You can see a little bit of, I don't know if this is the I presume this is the dura around here, and we're actually starting to enter into the brain there. And we go down a little further, you can see all the gyri and sulci, all those ridges that are in the brain that allow for more surface area and more brain nerve cells to give you more connections there. Go a little further, and we're seeing the gray matter on the outside, the white matter on the inside. Gray matter being more, I think, associated more with newer memories and higher functions. You can also see that the brain is split into right and left hemispheres. And now we're entering the first of those ventricles where the CSF circulates. The CSF circulates all around the periphery of the brain, but it's also being formed here in the center and starting to end flowing through those ventricles there. A little bit further down, now we can actually see the eyes there. You can see the eyes, also the orbits of the skull around there, the rear of those ventricles there, and the top of the pons right here. We'll go down a little bit further. This is actually the sinuses. So if you get a sinus infection or a sinus headache, that's your problem point there. You can see a really good, all the eye muscles right there. There's the nose, obviously. The ears, we'll see the ears over here, and also the let's see. So again, pons in the middle, cerebellum back here, and going down a little bit further, let's see, this is, I think I don't know if we're seeing the jaw or the palate there. For some reason, they do not show the maxilla, the jaw here. I'm not sure why that isn't part of this imaging here. Occipital lobe back here, top of the spinal cord, and eventually we're getting down to the two lobes of the cerebellum, top of the spinal cord there. Some major, these are the, I'm not sure which arteries or veins. The spinal arteries coming up there, and we're out. Let's look front to back. Let's see. Okay, and then we'll take a quick sideways view the other way here. So as you can see, here we have the actual muscles of the side of the skull there, and we'll go in a little bit. Whoops, which way am I going? There we go. And we're going a little bit deeper side of the brain there. These again are the sinuses up here, your maxillary sinuses. Going in a little further, and here you can get a good view of our forebrain, the occipital, the cerebellum back there. And we'll go in a little deeper. You can see the eyes and the muscles that control eye movement there. I believe this is some blood flow, part of what we call the circle of Willis, and I might discuss that in some detail. Here a little later, here we've reached pretty much the very center of the brain where the two hemispheres are divided. And connecting those is a structure around here called the corpus callosum. Some people have some very specific seizure disorders where they benefit from that being severed. Oh, here you get much better, much clearer right there, the corpus callosum. And that creates some very odd things where your verbal centers and your optical recognition center is split. So a person can look at an apple, for example, and say that is red and it's round, but they can't say the word apple. But then if you hold up the word apple, they can recognize that. It's a lot of very odd things when that gets severed partially or completely. And then we're exiting out the other half of the brain there. So that's a quick tour of the brain. Anyone want to look at anything else or have any questions about that or have any specific structures you want to look at? This has kind of some fascinating things. This will highlight the ventricles for us. So you can see them right there. And as you take your tour, the blue areas there are also, this will highlight the frontal lobe, the parietal, occipital, cerebellum, all that kind of stuff. So head, neck, brain, spine, pretty cool bunch of, pretty cool item there. Whoops, that's not what I wanted. Where am I? Okay, now I'll go in there and slideshow and view slideshow. Okay, this is going to start me right from the beginning. Okay, let me just go make you dizzy here, skull, brain pad. Okay, so here's the actual address, but go to headneckbrainspine.com, and those are, you can play around with that and learn a whole lot from that. So getting back to our bleeds, or our abnormal CTs, first up we'll talk about is an epidural bleed. So our outermost layer of those three meninges, those three protective layers, is the dura mater. So outside of the dura, you're going to have this epidural bleed. This is a bleed between the skull and the dura mater. It's arterial because that dura mater contains a lot of the arteries that feed the brain. So if you do have a bleed in this area, it's going to evolve very quickly and typically very catastrophically. Typically, you're going to have a loss of consciousness initially, and then they will regain consciousness for a little bit. So this is very important for EMS to know. If someone has had a loss of consciousness and then they regain consciousness and they say, I'm fine, they wave you off, there is a good chance that they could die an hour later. So these are people that do need to go to the hospital. Any loss of consciousness is worth a look-see with a head CT. Alert and lucid for minutes to hours, and then a rapid decline. They're walking around, they're fine, suddenly they're having this headache. And this headache, characterize it as, if someone says, I'm having a headache, and it is the worst headache I have ever had, or if it's the first headache I've ever had that was this intense, worst or the first, those are people that you probably need to get to an ER because there's a bleed somewhere, and they need to get scanned and probably get some surgery. And we'll show you some surgeries in a little bit. So this is our case study. When I put this together in 2009, this is fairly fresh in the news. Natasha Richardson, who kind of a B-list actress, probably biggest role was The Parent Trap, and here she is with Lindsay Lohan at the time, so it just goes to show, you know, how much time has passed since this. In any case, and probably better known for being the wife of Liam Neeson. Thank you. My next door neighbor is named Liam, so I'm like, Liam, no, not that Liam. Liam Neeson, who was in the Star Wars movies and all that kind of stuff. She was learning how to ski, going down the slopes in Canada, hit a tree, and had a loss of consciousness. By the time EMS got there, she was fine, feeling fine, didn't want them, and declined to be transported to the hospital. And within a couple of hours, she lost consciousness and she died because of an epidural bleed just like this. Rapidly expanding bleed inside that box. So when you have this sealed box of the skull and bleeding inside, you're shifting brain out of it, and there's really no place for it to go. I meant to show it on those images earlier, where your spinal cord enters the brain, enters the skull, is a hole about that size. That's called the foramen magnum. So if you have this sealed box and blood getting in there and pushing everything around, that's where things get pushed. So that brain will start, first the pons, and then everything will start herniating through this little hole, and it doesn't fit, and people die from that. So that's what happened to Natasha. There was another, an X Games snowmobiler, obviously earlier this winter, I think it was in November, who had a lot of complications, but among them was a brain bleed. And again, he had done something I'd never seen a snowmobile do until I watched the video of this thing. And apparently they were doing this in the X Games for the last 5 years, where they run the snowmobile up a ramp, do a flip in the air, and land. And apparently they stick the landing pretty well, but this guy did not stick the landing, and the thing bounced on top of him and went off. And being a big extreme gamer guy, after his short loss of consciousness, did get up. He did allow himself to be transported to the hospital, but didn't want C-spine and didn't want to be carried off, and he walked off. He didn't have any C-spine injuries, but he did have a brain bleed, also thoracic injuries, and just a giant frickin' mess that eventually very quickly died, actually. So here's a cadaver version of this with the skull removed, or at least the top of the skull removed. And you can see this giant clot here. And you can also see the arteries in the dura mater here. And if you have one of these severed by some sort of coup or counter coup or bouncing around inside there, this will bleed, and this bleed will evolve very quickly. To relieve this, we do trepanation, which is not a modern innovation. They have been doing this for centuries, and by centuries I mean Civil War era. And if you look at skulls from the Mayans in Mexico, literally 2,000 years ago, they would do this apparently pretty routinely. And why they were doing that, they didn't leave a lot of medical records for us to look at. Yeah, exactly, and HIPAA would protect them too. But they were a warrior society, so apparently, it may have been this like, oh, we're going to remove evil spirits kind of thing. I don't know, but it might also have been this warrior society with these guys who are getting these pretty catastrophic depressed skull fractures with bleeds underneath. And they would, in this image here, you can see not only, anyone can chop a hole in a skull, fine. This skull, it displays not only the trepanation and the holes cut in the skull, but it did heal back. So this guy survived this for a number of years. It doesn't have these like straight, we cut it and these nice sharp edges. This guy survived this, and the skull was starting to heal back over a couple of years before this guy died from natural or unnatural causes a year or two later. There are some skulls, they were trepanned like 3, 4, 5 times. And I don't know if those were serial or the same incident or something, but they had a pretty good success rate. This was, aside from amputation, pretty much the only thing surgeons did that people actually survived, especially with combat surgery, until easily World War II. And it wasn't until Korea that they started doing things like vascular grafts and something. So medicine was killing people right and left until they invented penicillin. But surgeons were saving a few people, and this is one of the procedures they were doing to save them. A little later, I'll show you a video of something involving this. Another kind of bleed is a subdural bleed. So I talked about our epidural bleed, or outside of the dura, underneath the dura. Now, obviously, you won't be able to diagnose these in the field. Our epidurals typically, like I said, were rapidly evolving and involving a loss of consciousness and then regaining consciousness and feeling fine until that bleed finally catches up to them. An epidural bleed is a bleed from a vein. So on the top of the dura, you tend to have a lot of arterial vascularization, rapid bleeding with pressure behind it. On the bottom side of the dura is the venous system. So injuries there, bleeds there are slower, involving some seeping, and they can be gradual. And by I say gradual, hours, days, even weeks. You have somebody, I've seen it a number of times in the ER. I've got this headache, and we CT scan them, you know, after kind of going through a few differential things, do CT scan and kind of come up with a fairly large epidural bleed. And then after we kind of question them, oh yeah, I did, you know, fall down the stairs like 3 days ago or a week ago or something like that. So the elderly and the alcoholics are a particular risk for this, and I'll show you why. When you mix, well, brain plus age, but especially brain plus age plus alcohol will produce some pretty significant changes in the brain. So here's an essentially normal head CT. You have all the gray matter I was talking about, the ventricles here. And you can see that not a whole lot of CSF here. The brain kind of cozies up pretty closely to the skull here. Here's a head CT of an alcoholic. And a lot of alcohol, or also age, will literally atrophy the brain. So here you can see, this is kind of an extreme example. I'm seeing slightly more extreme examples of this, where this brain has literally shrunk. And you have a whole lot of room here between the brain and the skull. So imagine that counter coup in somebody with a fairly snug-fitting brain in their skull. The brain kind of pads itself, but if you have somebody like this falling down the stairs, if you think about when you shake up a can of spray paint and that little bead in there, that's kind of what we're talking about here. That brain is just bouncing around all over the place, and that's these patients who are going to get either this epidural or those subdural bleeds. So someone who's drunk and falls down, I'll talk about that in a little more detail later, but if they're chronically drunk, they might have these cerebral changes there, and you need to be very concerned about possible brain injury. Another possibility is an intracranial bleed. Some internal artery or vein has busted open, and you have this diffuse bleeding into the ventricles. Okay, so before we took a brief break there, I thought that as we come back in, I'll show a brief scene from the movie Master and Commander with Russell Crowe, and this is an example, not a really close-up example, but a fairly realistic example of trepanning a patient who has suffered from a bleed. Here, I'll turn off the lights, and that's about a 2-minute thing here. And with our various tech issues tonight, I won't even bother with the sound here, but I'll just narrate this. They're repairing the ship after a battle, and Captain Aubrey is discussing some issues regarding the sails and masts. And here they're gathered around looking down into the gun deck, and what are they looking at? They're looking at Captain Maturin, or Dr. Maturin, excuse me, who's using a trepan to remove part of the skull from a gentleman there who suffered a depressed skull fracture in this recent battle. So he has sawed the skull open using that, and one of the sailors said, "Is that his brains?" He's like, "No, that is his skull." And now, after having sawn it out, he is removing the portion of the skull, and then he says, "No, that is his brains." And they all lean forward, and they're looking until I have a look, and they discuss. What an interesting guy. He's going to cover up that hole with a hammered shilling with some small nails on there, and then sew everything all back up. And they still do this sort of thing with some modifications nowadays. And along comes the master's mate and says, "Okay, you slaggers, get back to work." So they're going away, and then he's like, "Oh, what are they doing? Oh, well, that is kind of interesting." So that's that. So a little bit of trepanning for you. Oh, thank you. Okay, now let me see if I can get back to my PowerPoint here. And, oh, good. Let's start. Okay. So obviously we cannot cut a hole in the skull and manage these intracranial bleeds that way. These are pretty catastrophic and pretty much inoperable, and also, fortunately, very rare. We still, for the epidural bleeds, and also for brain injuries that don't involve bleeding, acute bleeding like this, but there is a certain amount of inflammation and the brain is swelling and starting to herniate out of that foramen magnum, they will still put sometimes some very large holes in the skull, sometimes even sawing out whole sections of the frontal lobe. And I had a patient when I was in school, in nursing school, and what they did was they removed that section of the skull, a pretty large portion of his frontal lobe, and they knew that at some point, once the inflammation came down, that they would want to replace that. So what they did was they put an incision in his abdomen and just placed it in there in a moist, sterile environment there. And apparently that was a nice place. It didn't need, apparently, blood flow to it, but it was a safe place to keep it until they were ready to pull it out and put it back on. So one of my instructors kind of was explaining this whole procedure, was aiming to explain this whole procedure to our class, and we were all kind of gathered around his bed on rounds. And kind of her introduction was, do you want to see his skull? And she started pulling down his blanket. And we thought we were going to see something down there. Well, you know, a lot of guys' brains are down there, but I didn't know the skull. But he had this pretty significant lump in his abdomen where they were storing that until they could replace that. So more often, what you're going to see is traumatic brain injuries or diffuse brain injury. And this is becoming so common with our returning veterans from the wars in the Middle East. Concussions from explosives, roadside bombs, RPGs, all this kind of stuff is putting a lot of pressure, just diffuse pressure on the brain, or throwing them across the room or something like that. So they have a whole lot of concurrent injuries, but they also have this head that's been impacted pretty hard, didn't have a specific bleed like that, but they've lost a lot of function, either memory, speech, long-term memory, some of these, impulse control sorts of things like that. Our research on this, we're learning more from this every day. Now, the VA is really overwhelmed by the mass of this, and some of these maybe are being undertreated, but there are a lot of returning vets who have these to a lot, sometimes great extent, sometimes lesser extent. And I'm going to talk about another population that's been experiencing this also. But a lot of research on this is ongoing, and the proper way to do therapy to get these vets up and running again. Now, if you have a problem with the head bone is connected to the spine, the neck bone, or the spinal cord. So I'm going to talk a little bit about cervical spine stabilization and cervical spine injuries. So then there are the other sections of the spine also, but it's the neck bone that I'm going to be concerned about here. So the cervical spine, if you have significant trauma, blunt or penetrating trauma to the head, you need to be very cautious about trauma to the cervical spine. Now I'm going to throw a little trivia at you. There are a lot of classes of animals in the animal kingdom, but mammals always have seven cervical vertebrae. So mammals being the ones live birth, we have fur. Females can feed the young with milk, and those are our mammals. So a cow, how many cervical vertebrae? Is it a mammal? Yes. So how many cervical vertebrae? It's got 7. Who's gone over to my neck of the woods, to Lincoln, to Morrill Hall, and looked at the skeletons of the woolly mammoths there? Mammoths, they're furry, live births, gave milk, they're just like elephants. How many cervical vertebrae? You can see, look at Archie, he's got 7. I was just down there with my kids the other day. Okay, now here's kind of a wacky one. Giraffe, is it a mammal? How many cervical vertebrae? 7, exactly. They're big. There are 7 of them. I'm glad we don't have to stabilize their C-spine. So C-spine stabilization. I do another talk, and I actually gave it last night over in Omaha. I was like, wherever the heck I was, in Papillion. about various myths and various practices we have in EMS that are transforming under the pressure of research. And C-spine stabilization is one of them. So let's talk about the disadvantages of C-spine stabilization. And there are many of them. This is not research. This is just things those of us who work in EMS know. Aspiration risk. And I had a patient in the ER being brought in by EMS the other day. A gentleman with a ground level fall, older gentleman. So they had concerns about bone loss and maybe he had neck pain, maybe not. But after the fall, he started vomiting. So here's an actively vomiting patient, supine with this collar around his neck. It is just an ugly situation where you got to be very vigilant with their airway and do suctioning and things like that. So airway management and then intubation and those sorts of things are a lot more difficult if you've got to keep that C-spine straight with a collar. It increases intracranial pressure. So if you put a patient supine, keep them supine, and have this big thing on their neck, that's going to increase intracranial pressure. Well, if we have a C-spine injury, we probably have a head injury too, and that is not going to be helpful for that injury. This is the one that we've had big concerns with in the ER, the pressure sores. If you have an elderly patient, not much fat on the bones there, and you have pretty much bone on this hard board, you have a great incidence of pressure sores. So when those patients come into the ER, we try to get them off that spine board just as quickly as we can. And that is a patient who is alert, who is sober, and who will be cooperative, and will lay still and flat. And not a whole lot of our population who's falling down always matches that criteria. It's expensive. In drunk patients, it increases combativeness. It will keep them down there, but they're not going to like it. It's time-consuming, difficult to remove difficult to get them off the board without a whole lot of torquing and twisting and turning. And then it frequently fails to achieve that neutral alignment that we really want. Now, who in their EMS training or in drills and such, they put you on the board and then they march you around the hall or flip you upside down, all that kind of stuff. And in a controlled classroom situation, you can do that. But if you have somebody who's drunk or demented or moving a lot, getting them on a board really securely to our level of care that we're aiming for can be very difficult. So there are a lot of concerns with C-spine stabilization, and they're doing, people are doing research to figure out, is this really the most effective thing? Is this really what we need to be doing? So in Baylor University, they used cadavers to look at some interesting things. And then Washington University in St. Louis, they did some motion capture studies. And I'll talk about this in a little bit. Well, let's look at the Baylor study here first. They took a patient with a C-spine, C2, it looks like C2, C3 fracture. I am not sure if she was a donated cadaver who had this, and they said, good, we can do the study, or if they took the cadaver and did something to break it. But this is what we ended up with. So patient neutral alignment, and then we put a collar on her. Maybe not the most appropriately sized collar, and she had this C-spine injury that they have really put way too much traction on and exacerbated. Now, this is first of all just one patient. They're just kind of like, well, let's give this a whirl and see what happens. And this is what happened. In your conscious patient, definitely in your alert patient, they will not, if you start stretching them like this, they're going to say, no, that is really wrong. Please stop doing that. And hopefully a savvy provider will figure that out. Even an unconscious patient, I think, will have a certain amount of muscle tone that a cadaver lacks. So this will not happen. So it's kind of suggestive of a worst-case scenario, but not very conclusive. Now, the Washington University study did some really interesting stuff with motion capture. This is the technology they used to film Avatar and to film Golem and Lord of the Rings. And anyone see Tintin? God, what a great frickin' movie that was, and nobody saw it. Same kind of thing. Yeah, okay, good. So for Avatar, they put dots on the actors' faces, and this little box here is actually a little facial camera. Now, this isn't what they did for this study, but also these actors have these little dots all over their body. They're filmed from multiple angles, And these motions of the actor are fed into a computer, and they can tell exactly on each dot where that person's, where that actor's arms and legs and hips and all that kind of stuff are in space. And they can map that out, so then when they make the film, they can generate a computer image from any angle of that character. So that's what these folks at Washington University did, but instead of turning them into alien creatures, they put them in cars and had EMTs collar them and take them out of the car to see what moved where, what was twisting, what was turning, what was staying in alignment, and what was the most effective way to get them from a car onto a backboard and into an ambulance. And this is what they found. The least motion of the cervical spine was in subjects who had the cervical spine applied, and they were allowed to get out of the car and lie down on the stretcher. Now, my initial training was in DC in Maryland, and there that we were flogged mercilessly with the KED, the Kendrick extrication device. And this was our standard of care, and we did this for anybody in a motor vehicle accident where there was any suspicion of cervical spine injury. We would put the collar on, lean them forward, get them on. It took a lot of people. It took a lot of time, and we got them out of the car. This was actually in their study created the most C-spine motion during extrication. So then this was my standard of care coming out here, and then I go to Creighton for my paramedic training, and my first MVC on Omaha Fire in clinicals. We go out, and they put a collar on them, and they say, okay, get on the car and lay on a board. And I'm like, you're going to kill these people. Now, I don't know if it was laziness or if this was certainly way behind before this study, but that was their standard of care. And it turns out that seems, according to this study, the most effective way to do it with the least amount of torquing and twisting and turning. Certainly a lot less labor intensive and certainly a lot faster. So again, not conclusive, but very interesting and worthy of further study. Some other things we've looked at a little further back is what we call the nexus criteria. The origin of this study is not from EMS, but these were emergency physicians who were doing head CTs and neck CTs on tons of patients and saying, do we really need to be CTing all these patients? It's very time consuming, it's very expensive, and you're exposing these patients to a whole lot of radiation. Do we really want to do this? So they looked at a set of criteria that would kind of exclude people where they said, we don't need to do head or neck CTs on these patients. Now, certainly, if they had suspicions outside of these criteria, they would absolutely have prerogative to do these x-rays, just as you as a field provider can look at these patients, and if you have any kind of suspicion, even on a ground level fall, well, she looks real old, she looks real bony, I just don't like the looks of this, you can certainly collar and backboard them. But anyway, these were some things they were looking at, and 99% sensitivity, and this is their criteria. First of all, no midline C-spine tenderness. So you press pretty hard on the C-spine. No, everything feels fine there. Okay. No neurological or focal neurological deficit. So no numbness or tingling in one arm or one leg or something like that. Normal level of alertness. They aren't sleepy. They aren't drugged. No evidence of intoxication, because your intoxicated patients are not accurate historians. And they can tell you, no, that doesn't, that feels fine. And they may just be messing with you, or they may just, not feel it because they're intoxicated, because they're anesthetized, self-anesthetized, self-medicated. And then no distracting, painful distracting injury. So if they fell down and they've broken their ankle, and that's very painful, you could press there all day, but they're thinking about their ankle, so they really can't give you an accurate report of their neck injury. So if they meet all these criteria, they would consider them a no-risk patient, and you could pretty safely, at a 99.6% level of sensitivity, pass them through without doing C-spine x-rays. Another more recent one, again coming from physicians, but with an eye toward EMS, is what they call the glass intact protocol. Who subscribes to GEMS, Journal of EMS? Okay, you should, because GEMS used to be kind kind of a mouthpiece for their advertisers, and now it is becoming a really good research journal. And the changes you will see in your practice in 5 years or 10 years are being published in this every month. So I'm going to pass this around for you to have a look at it. If you've ever seen it, great. If you don't subscribe, reconsider, because you should. And if you've never seen it, have a look. It's really turning, in the last 5 years or so, really turned into a really fine journal presenting research like this. In any case, the Glass Intact Protocol, they were looking at a database of 14,000 crashes from the National Highway Traffic Safety Administration. And this is what they saw as criteria for patients who are at very little risk, or 99.92% no risk for C-spine injury. If the vehicle was towed from the scene, if it wasn't drivable, you should suspect a C-spine fracture. But if it was drivable, low impact, you probably don't have a high suspicion for C-spine injury. Fairly healthy patient, age 16 to 60. Now, certainly you can have middle-aged patients with bone density problems and things like this, but this is our typical, good nutrition, good bone density, strong bone kind of patient. So if they're in this age range, again, with meeting all the criteria, safe to send them without a collar. No damage to the vehicle windows. This was like the first thing they started looking at, and they could get this from EMS and police reports. So if either the patient, if there's no damage to the patient, to the windshield, it tells you two things. It tells you the patient's head or arm or whatever did not impact that windshield, and B, the impact wasn't significant enough where we had damage to the glass there. No airbags deployed. Now, certainly if a patient is rear-ended, that's a whole, you're not going to get those airbags deployed, but we have all these other criteria. And they need to meet all these criteria. And then finally, the front seat occupants, and these are the ones we're specifically looking at in these studies, they were restrained. So they were finding patients who met all these criteria were very, very unlikely to have a C-spine damage and could safely be not collared. So again, not conclusive, but a very fine study, very suggestive of looking towards some alternatives or ways to kind of avoid unnecessary C-spine stabilization. Now, I can talk about this here in these studies, and they're all good, but you have your protocols, and your protocols are probably very clear about who should be stabilized. So this is not the place to have a discussion about research and protocols. If you have protocols, follow your protocols, but be aware that they may be transformed in the years to come. And also, I think there are people working on alternatives to that collar, which is really one of their big problems there. So full body vacuum splints and the like. They're trying to figure this out, and there's some, obviously have the good of EMS and the good of humanity in mind, and some people just say, if I invent the right thing, kind of like the KED, I'm going to make $1 million. So between one of those impulses, I think we'll see some big changes in the next 10 years or so. So here's our intermission. I'll show you the video. I already did. Okay, moving on. Any questions about that? Making sense? Okay. So I've talked about anatomy and the brain and the skull and what happens inside, and now I'm going to put a little more emphasis on how all this plays out on the outside and what you're going to see. So certainly a patient who's had a period of unconsciousness needs to go to the hospital, and you need to be very vigilant with them. But there are a lot of more subtle signs out there of various things going on inside the skull and the brain. Excuse me there. Okay. Now, part of my my original presentation, as I put it together in 2009, that's at odds with my EMS Mythbusters lecture that I did yesterday that I was talking about, is the Glasgow Coma Scale, which more and more providers are saying is basically useless, specifically in the EMS environment. Now, I know the Glasgow Coma Scale is an essential part of, I know in Nebraska, our documentation. Is that required on your EMS documentation here also? So for good or ill, until that trickles down, this stuff trickles from academia and then into practice, and eventually it'll get to the government. So maybe that will disappear at some point. But the Glasgow Coma Scale was originally put together for neurologists to keep track of the progression of a patient's neurological status. And even the neurologists now are looking at that and saying, this is not a good predictor of survival, and is so confusing, isn't really a very helpful predictor of anything, or a really good assessment. And what a lot of EMS people now are saying, well, you're going to probably need to do the Glasgow Coma Scale for your documentation, but you really need to be talking about is reporting all these things objectively, and their eye motion, and their motor function, and their level of consciousness, and all that kind of stuff, and just put that in your report. And saying a Glasgow Coma Scale of 6 is not helpful, because of everything in so many different ways. So we'll talk about that. We'll talk about the Cincinnati Stroke Scale and the NIH Stroke Scale. Cranial nerves, lots of fun, and those of you who have done anatomy classes, you can feel free to fall asleep for that 10 minutes. And then I'll talk a little bit about pupils too. So the Glasgow Coma Scale, 1 to 4 on eye opening, motor is 1 to 6 scale, verbal response 1 to 5. So a patient who is dead has a Glasgow Coma Scale of 3. So that's one unhelpful element of this. And then just remembering which is 4 and 6 and 5 is all. It kind of was difficult to me until I came up with my own goofy mnemonic. And I don't know if you need one, but what I always remembered was eye motor verbal, EMV, emergency motor vehicle. And emergency motor vehicles have their front lights about 4 feet off the ground, the next lights are about 6 feet off the ground, and the back lights are about 5 feet off the ground. I have so many wacky mnemonics like this packed in my poor little brain, so I don't know if that's going to be helpful to your Glasgow Coma Scale at all, but it's free, no extra charge. So we're looking for, if we have no eye opening at all, that's nothing, it's all spontaneous, waking to voice. And this is what I put a lot of times in my nursing documentation. RN enters room, opens eyes to voice, opens eyes to pain or noxious stimuli, or just, opens eyes on RN entry to room. Motor response, they're going to obey commands, they're going to localize, withdraw from pain, and then our flexion and extension are really bad kind of seizure activities, or that's signs of brain herniation. We have swelling in the brain, and that brain is starting to drain through that foramen magnum, and they're having these just catastrophic circling the drain, about to die kind of motions of the arms and legs there. Verbal, they're oriented, confused but converses, inappropriate but comprehensive. I bet that's a typo. But, I don't know. Sorry. And then comprehensible maybe, and then incomprehensible sounds, and then none. Again, you get that if you're dead. And then just to complicate things even further, so the way this is typically put in EMS, if they're less than 8, they definitely need airway protection. So you're going to intubate them or use whatever's out there. Over 9, the literature doesn't back this up, but what they typically say is if it's over 9 on your arrival, and it maintains 9 during your transport, that's a good indicator of survival. But keep in mind that Natasha Richardson, in her early minutes, was a good 15, and then rapidly went down to probably 5 or so, and had some big problems. Let's talk about the cranial nerves. These are nerves that have tracts that go through typically the floor of the skull. So if you have most of our nerves go through the body and enter in through the spinal cord, but there are a few kind of wacky nerves that, for example, the optic nerve that goes from the eye and then travels along the floor of the brain and goes into whichever of those lobes there, and I can't remember which one it actually enters into. So if you have abnormalities in the nerves, that tells you have a bleed, increasing pressure, or sometimes a tumor in a specific part of the brain. So I'm not going to have you, as I would in a full-blown anatomy or physiology class, memorize these. And certainly in the field, you're not expected to do a full cranial nerve exam. But if you are flogged through an anatomy class or a nursing or physician assessment class, you'll be running through these. And then a neurologist will be able to do all 12 of these in about probably 30 seconds. So the olfactory nerve is the nerve of smell. And it goes from the nose into the brain pretty much directly into one of the lower levels, the pons, I think. So you probably won't be asking your head-injured patient if they can, hold a alcohol wipe and can you smell this? Not a field thing, but that is the first of our cranial nerves, the one that goes in most directly to the memory centers there. Optic eyesight. So if somebody has been hit in the head and they say they're blind, well, that's a red flag, and I'd like to think that you would have realized that anyway. A couple of these others, the oculomotor, the abducens, and another one on the next slide, control eye movements. And they're very specific ones. One controls the lateral movement, one controls up, down, one controls the eyelid. So typically, the way to test all these pretty quickly is to do a full circle, round, 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 and then a G across. So you're testing the lateral motion, the up-down motion, and the obliques, which do a kind of diagonal one. Trigeminal controls both motor and sensory to the mid-face. So light touch, can you feel this? Can you feel this? Can you smile? All that kind of stuff. And obviously that's going to be part of our stroke scale too. Facial nerves also, controls nerves of the face, but very much the other areas, the front of the eyebrows, things like that. Auditory, if someone says they got hit in the head and they're deaf, well, that could be maybe from a concussion if they've been in a combat injured patient, but that's less common here, obviously. But someone who's lost hearing obviously needs to go to the hospital, and you need to be vigilant with them. Speech and swallowing are controlled by this glossopharyngeal one. We have some serious airway issues there, so if they're having problems with speech or with moving their tongue and such, be very concerned about airway. The vagus nerve, you could write a whole book about the vagus nerve because it is a cranial nerve, but it also tracks through the thorax and into the neck. So when you have patients with a high heart rate who are tachycardiac and you ask them to do the vagal maneuvers where they ask them to bear down, that increases the pressure in the chest, and that stimulation slows down the heart rate. But that nerve also tracks up and through the skull. So low heart rate could be an indicator of, well, it's also going to be an indicator of increased intracranial pressure, but it could indicate that's going to be because of the stimulation to this vagus nerve there. Spinal accessory, that's the nerve that controls the shoulders, and just doing shrugging like that is another one of these cranial nerves. And then the hypoglossal, that's the tongue, and that controls can you talk, can you speak, and go ta-ta-ta, pa-pa. Well, not pa-pa-pa, that's facial. So patients having problems controlling their tongue, protruding their tongue straight out is an issue. Somebody sent my wife something on Facebook that said, I'll talk about the stroke scale, but they said, there's this new addition to the stroke scale where you ask them to stick out their tongue. And that has not kind of trickled up to National Institutes of Health and our stroke scale there. But well, it's part of that. But it isn't one of our Cincinnati stroke scale things just yet. So let's talk about strokes. About 800,000 of these annually in the United States. 20% of them are hemorrhagic. So these are the patients who, in the absence of head injury, are reporting that headache that's the worst or the first. This is the first headache I've had that feels this weird, feels this intense, feels this bad, or I get headaches and this is the worst headache I've ever had. If they're having a hemorrhagic stroke, you'll be lucky if they can talk to you by the time you get there, because if that's recognized initially and you get there soon enough, they'll be talking, but they're going to go downhill. If you have a significant bleed, especially one of these like intracranial ones, which is what is more characteristic of a hemorrhagic stroke, where the bleed is in the middle and is inoperable, not one of these easy subdural bleeds, these patients are going to go downhill very, very quickly. More commonly, we have ischemic strokes. There's a blood clot that is either formed there like a plaque, kind of like a heart attack, or a blood clot that has migrated into the brain from somewhere else and is blocking one of those cerebral arteries. So you'll have very specific signs and symptoms on these patients. And then a variation of that is a TIA, a temporary ischemic attack, where that blood flow is interrupted, but those signs and symptoms last less than 24 hours. So they might resolve before you get to the hospital. And this may be due to some sort of spasming in a cerebral artery or something like that. They'll still get a very close workup, and these patients are at risk for a real permanent stroke within the next year. So they will be put on very specific medications. But obviously, those signs and symptoms need to be checked. So how do these play out? Then the golden hour of our stroke scale. You probably know this. We need to get these patients to a stroke center, and most ERs nowadays, even our critical access hospitals, can give TPA or other clot-busting medications. So if a patient does have an acute blood clot in their brain, you can give this medication and dissolve that clot and get everything thinking and moving and working again. But it needs to be given, they initially said within 3 hours of the onset of symptoms. Kind of widen that to 4, and I think that's going to be going to 6 in the next couple of years here. There are very, very specific exclusion criteria for these patients. I won't get into those here, but any bleeding issues, certain age issues are excluders, recent surgeries, because if we're putting in these clot clusters, then they might have other clots elsewhere that could start rebleeding, so we don't want to get those started. So, but if we can go through that, I have seen this stuff work, and it works within a couple minutes, and it's just a miracle. There's also a risk of death, or rebleeding and such. So we need to explain that very carefully to these patients and their families, and you give it, and you get things all moving again. So it's pretty remarkable. So our first element of getting these clot busters to these patients is recognition in the field. So that's why there is a lot of public education of recognizing the signs and the symptoms of a stroke and saying, you need to call 911, you need to get to the hospital. They need to get in fairly quickly. We're going to shuttle them right over to the CT scanner to make sure this isn't a hemorrhagic stroke, because we certainly don't want to give clot busters to a patient who has an acute bleed in their brain. So excluding them, getting them to CT, having that CT read quickly, getting very specific labs and such going, and then getting to that definitive treatment and doing that within a 3-hour window of those signs and symptoms. So if a patient wakes up with stroke symptoms, we do not know when that stroke started because they can't tell us. So they unfortunately are excluded from this. So if they can't give us an accurate history, we need to say, when were they last seen normal? So did a family member see them get up and go to the bathroom without falling down or tripping or speech abnormalities and all that kind of stuff? So if you do have an acute clot in the brain and some sort of interruption of the blood supply to a certain portion of the brain, a certain portion of the brain will die. And then there will be a certain part around that that's at risk that will have a certain amount of ischemia. Very much like exactly like a heart attack, only instead of muscle, it's brain tissue. And once that tissue that dies, it is dead and is not going to be restored. So how quickly we can do them, treat them, and how really is the determining factor of how much function they can regain with physical therapy and speech therapy and such over the next day, week, sometimes years. And there's going to be a certain amount that's not going to be recovered. So what kind of damage they'll have and the extent of that really depends on where that clot is and how much is clotted off there. So our Cincinnati stroke scale, this will be our rapid look at are you having a stroke, or is this looking like a stroke? So our face, if we have an asymmetrical face, give me a big smile and one side is going up but the other one isn't. That's a problem. We need to run them over to the ER. Arm drift. So the way I phrase it is, put your arms up like a mummy. That's what I used to say. Now I say, put your arms like a zombie. And I keep them up, keep them up, keep them up. And some of these older folks are kind of shaky. But if we have one arm kind of drifting off, that's a problem. And then the Cincinnati stroke scale, how's your speech? So you give them a fairly complex phrase to say. That checks their ability to hear it, to process that, to use their speech centers to say that, and then to use their lips and their tongue and all that kind of stuff to actually enunciate that. So in the absence of any other pat phrase that I say, I usually ask them to say, can you say Cincinnati stroke scale? Because that's the first phrase that comes to mind, and that tests a whole bunch of stuff. And once you get to the hospital, somewhere they're going to be, like I told you, run them to the CT scan. Some of my ER providers don't even want to look at them. It says, get them to CT, and I'll get a look at them when they come back. When they come back, they're going to run them through the National Institutes of Health stroke scale. This one, I won't go into the details of. Certainly, we're not in Kansas anymore in terms of our 3-point stroke scale, and this is even more complex than our Glasgow. It involves very close looking at most of the cranial nerves. Can you stick your tongue out? Checking that proprioception. They have them, they hold their hand up, hold your nose, okay, now go here, go there, go here, and they'll move their finger around. Checking that with both upper extremities there. They'll show them this picture, ask them what's going on in this picture, really sensing those looking at those higher functions. And if they, well, there's water spilling, he's trying to steal cookies, that's the kind of stuff, we don't have to have a real exact thing there. Eyebrow raise, smile, moving the heel to the shin back and forth. Now, a lot of our older patients can't do any of this stuff, some of this stuff on a good day. So this can really confound it. But this one is a really good indicator of progression and neurological progression and whether they're deteriorating or getting better. So in my hospital, which has a certified stroke unit, in fact, we got this like double gold blah blah something because we use TPA a lot and use it very successfully because we've refined this to a really well-oiled NASCAR pit crew procedure. Anyway, our nurses up on our stroke inpatient unit are trained in this, and they will run their patient through this about every 6 hours to see, are we getting better? Are we declining? Do we need to get more stuff going on there? So a real savvy provider can run a cooperative patient through this in about 5 minutes if the patient can do all these cooperative things. If they're comatose or demented, all this kind of stuff, that kind of complicates it. And like the Glasgow Coma Scale, even on a good day, I don't know if I would rate a full 42. There are a couple of the proprioception ones that I have some balance issues. So, but we get a baseline, get the CT, get a baseline, and then we keep pretty close track of this here. Pupils, pupil function. This is going to be another good indicator of looking for potential brain injury. But pupils do some very odd things. So then consider our charting Pearl or Perla, and that typically stands for pupils are equal and reactive to light. And if you do Perla, equal and reactive to light and accommodation. That accommodation is if I cover up this eye here, and that eye to compensate for that starts to dilate and get bigger. This one will to a certain extent too. If you shine a light in it, this one will constrict, and also this one will constrict too. So you got to keep track of what you're shining in and be looking at both pupils and all that kind of stuff. One of my paramedic preceptors used to just cover up the patient's eyes and then open them like that. And he thought that was like a completely, it just looked odd. It looks a lot more professional to do a light. He was an odd guy anyway. But pupils can do some odd things. Some people have a naturally dilated pupil like this. If you go to the eye doctor, get those eye drops, and then they give you tell you to wear eyeglasses. But some people are going around like this all the time. Some people have had eye surgery. So if you're shining lights in there and that light isn't doing anything, you can say, have you had some eye surgery or something like that? Oh yeah, you know, cataracts or well, LASIK doesn't do it, but or you know, I got hit in that eye when I was a kid, and it always looks kind of weird. So you don't immediately jump to the conclusion, oh my God, this patient has this catastrophic brain injury, and there's no reason they should be talking to me. Do dig in a little deeper. So here's an example of this with a person with there is a specific medical term for this, which I'm sure I knew in 2009 when I first presented this. But we'll have this permanently dilated eyeball. David Bowie, the musician, has this, and which I never realized until I saw it on a website. And look at this, isn't this weird? So if you ever have to do a stroke scale in David Bowie, do keep that in mind. Very, very completely constricted eyes typically are characteristic of opiate overdose. So if you have an unresponsive patient and you open up those eyes and you're seeing something like this, keep that in mind as part of your differential. There's some organic causes for this too, but that's your typical one for that. So any questions up to this point? Making sense? Sounding good? Okay, I'll conclude with a couple of other things here. First of all, alcohol is your biggest confounder for all these neurological assessments. Your patient may be uncooperative. They may be just trying to mess with you. They may have a decreased level of consciousness, and it may be very difficult to differentiate that from alcohol intoxication from a brain injury. If you want to, a lot of people die. Let's see, how do I phrase this? Obviously, a lot of people die. Some people get substandard care. But when people who are related to journalists get substandard care, very big changes happen. In the 1990s, there was a woman named Libby Zion who died in a hospital in New York because, and what it was ultimately blamed on was a resident who was doing overnight. He was on like the 38th hour of a shift, and overwhelmed with like 70 patients, excuse me. And she happened to be the daughter of a New York Times, a very highly placed New York Times reporter. So her death was all over the news, and the end result of this was big changes, at least on paper, in the nature of residency training and the amount of patients that residents could take and the number of hours they could work in a week and also on end. So taking that overnight, working a day shift and then taking night call and then working half the next day is still out there, but a little more rare and than it used to be. In early 2000s, I think it was 2005, somewhere thereabout, DC Fire picked up a gentleman who they presumed was intoxicated, and they just threw him onto a cot and took him to the hospital. It turned out it was a New York Washington Post reporter who had been mugged and had a very profound brain injury and did die. So there again, anyone's death is tragic, but a reporter's death is going to lead to some changes. And DC Fire, which was already down on the ropes, really suffered under that. And they have kind of recovered from that, but they still have some pretty profound issues because it's a very complex city, suffering a lot of budget problems and all kinds of issues. So I will just caution you that a person who has a decreased level of consciousness and may have an odor of alcohol and may be acting drunk, you can consider the alcohol intoxication as part of your differential, but keep in mind they might also have a head injury, a spine injury, God only knows what else going on them, and because they're such a poor historian, either from the alcohol or the head injury, they can't tell you what's going on with them. So be concerned about that. I'm going to talk a little more about traumatic brain injury and diffuse brain injury, and especially in sports. And this has come up so much more often in the last 5 years, they have focused on high school sports, college sports, and head injuries from those. And I know a lot of people have had these pretty profound head injuries, and it isn't a bleed, it's an epidural, subdural, intracranial, there's no bleed. But if your head gets smacked in a sport, in a car, something like that, every time that happens and that brain is bouncing around in there, no matter how much room you have in there, there are going to be axons, there are going to be brain cells that are going to come apart, and that will lead to memory problems, motor function problems, coordination, all this kind of stuff. So the real focus on this has been in high school sports and college sports. So it's very common now for them to do pre-season assessments on all these young athletes. You know, can they do, they run them through memory tests, motor function tests, balance tests. So then if they do have a big hit in the sport, they can run them through these again and see where they have deficits. So if you think of, you know, some of your dumber athletes that you knew in high school, and on a good day they were kind of like we do assessments before and get a baseline, and then if they do have a good head impact, we can see if that's affected them. I was just reading the other day about some folks now with an iPad. You can do these studies right on the sideline right after these injuries. So this guy took his iPad. The test he was running him through was kind of cool. It was like, if the top right corner of the screen lights up, you need to hit the lower left. So it's not like a test of quickness. It was to a certain extent, but also testing some of the higher cognitive functions. Okay, I don't need to hit there, I need to hit there instead. And so he had this high school soccer team, females, and they were doing a lot of heading of the ball. So after they headed the ball 2 or 3 times, run through these tests, and their abilities were going down. And this is not a big hit. So they would regain their abilities fairly quickly. Well, this can have some long-term implications, especially if you have a kid in football who's doing head impact after head impact. And we used to kind of poo-poo these, you know, the footballers are, you know, shaking it off. I'm okay, coach. But long-term, all these repeated impacts have their effect. If you think of Muhammad Ali, who used to be, you know, the biggest boastful kind of guy, and had these, after a whole career of taking those hits, had these pretty profound Parkinson's changes, and eventually died from, you know, a lot of neurological changes. So keeping that in mind, and here's a fun case study. I was in an airport van. I was stuck in Denver and taking the van to the hotel. And the guy next to me was talking to his friend. He was from England, and he had been in a motorcycle racing accident when he was a kid. And he was, I think, knocked out. He couldn't remember. He definitely couldn't remember the event. Went home, didn't go to the hospital, of course. And if a British National Health Service, I don't know if he would have gotten a CT that night anyway. In any case, went home, had to stay in bed all weekend. They finally called the family doctor, who came in and to the house and assessed him. And he said, "Well, your kid's on drugs." That was his conclusion. He's like, no, I'm not on drugs, man. And yeah, and he had deficits for another year. He could not be in rooms with bright lights, couldn't go out in the bright sun. Not that you had bright sun in England that much. And concentration issues and things like that. Was a walking, talking, fully functional guy now, but it can take a while to bounce back from this kind of stuff. And a usual kind of treatment of this is rest. And when you say rest to a teenager, that means watch TV and video games. And when they say rest for these traumatic brain injuries, they mean dark room, don't read, don't watch TV, certainly no video games. So try to tell a teenager to do that for a week. But eventually, if you can do that, these axons will repair a little more quickly. This is the concussion studies lab at the Cleveland Clinic. And they have like you do crash test dummies with cars. They're testing crash test dummies with football helmets. And they have sensors in here. And they're crashing these things together at like 75 Gs, 75 times normal gravity, which is pretty typical for a football impact. And what they're finding is these are not any more protective than these helmets. So these are a lot cooler. Maybe we should just go back to these and realize your kid's going to get hit and could have some long-term difficulties. So this is the kind of stuff that's out there with these teens. So fortunately, there's a lot more awareness about this now. When they do get hit, especially when they have definitely a loss of consciousness, but afterwards any sort of neurological problems, their pediatricians are typically getting these. Usually the schools are requiring them to do these baseline motor and sensory and balance and cognitive function tests before the season. Their pediatrician gets these records and they can run them through these again. And this is being financed typically by the school system or somebody like that. So, and they're making it a requirement. And they're going to miss a game, but this is the catchphrase. It's better to miss one game than the whole season. So if you're doing first aid standbys at your high school or even Pee-wee football, I talk to Red Cross every once in a while and they run Pee-wee football. And there's this like woman in her late 70s who her specialty is doing the first aid team for Pee-wee football. And they say she is a monster. Somebody gets knocked out. She's like, that kid is off for the rest of the... You know, she's very quiet in class. We're like, don't take her to a game. You just get out of her way. And she will make sure if these kids get a good hit to the head, they are out of the game for the rest of the game there. So a lot of resources out there. National Foundation for High School Sports or something along those lines. MassachusettsGeneralHospital.org has a really good guide for coaches, athletes, and families. CDC, obviously, really good literature they call Heads Up, and I think they're the source for this one here. And again, once again, it's better to miss one game than the whole season. So that's what I got for you here. Yeah, sure. Yeah, sorry. NFHS, I forget what it stands for, but that's the right combo of letters, .org. I think it's National Foundation of High School, blah, blah, something. CDC, definitely, they're all over the place with it. And then I just found this Massachusetts General Hospital one very helpful too, and when I was doing another talk on this specifically. Questions, comments, thoughts, arguments? Concussions. If you have another question that occurs to you later, do feel free to email me. If you want more information about anything like this, if you start getting into arguments with folks at your station or your medical director about C-spine stabilization, I can send you all the references and information about those sorts of issues. If you want to hear me droning on further, you can follow me on Twitter. And any talk I have coming up, I will post on there. So my next one is going to be at St. Elizabeth Hospital in April sometime. I'm talking about medical emergencies on commercial airline flights and the kind of resources and training and personnel you can expect on those. Whoops. And then also, I work overnight shifts, so 4 in the morning. A lot of times I'm posting really crazy stuff on there. So a lot of cooking stuff, a lot of movies, a lot of music. So I say a lot of crazy stuff. But so if you want to read, anyone else do Twitter? Nobody. Okay, great. Well, don't bother. Okay. Yay. Okay. So that's what I got for you. Thanks very much for staying awake. I appreciate it. And see you around. Maybe I'll be back here again sometime.